after we've had the presentation, and then there'll be an opportunity up to 2:40 for people to make us aware they'd like to ask a question, and to be able to do that to any member of the board, but perhaps even particularly focusing their questions on COVID-19 and the issues that we will have just discussed. So without further ado, I'm going to hand over to Andrew Ayres and Ruth Hutt to just give us a sense of what's happening at the moment in the borough on COVID-19, particularly vaccinations, testing and COVID prevalence. So Andrew and Ruth.
Yeah, thank you, Jim. And I think we're just going to put up a few slides. We've got 5 slides and there's a number of people going to speak to them. So can I just check the slides going up? Can we do them as a slideshow? And could I ask if anyone else has got their mics on, could they put them onto mute? Otherwise we'll get some background noise and we won't hear everybody. So okay, thank you, Cheryl. Do you want to go to the first slide? And I think Ruth's going to give us an update on the kind of epidemiology and prevalence of COVID. Thank you, Ruth.
Hi, everyone. So I guess very quickly, it looks like we have passed the peak of the incidence in new infections, probably around the 11th of January. So they are starting to fall. London still has the highest rate of new cases in the country. But it certainly, it was sort of plateaued probably the week before and certainly starting to fall now. But I have to say the rates remain very, very high. So even with that fall, they are way, way above where they were when we went into November, December. The hospital admission rate is still very high. Lots of people in hospitals and in intensive care. And there will be a lag between the new infections and the peak in infections and peak in people in hospital. There will be usually at least a 2-week lag to that, possibly longer, because people are in hospital for a long time. The other thing I guess to note is we are now starting to see a rise in deaths. So that has become apparent probably more in the last 7 to 14 days. And sadly, that's likely to continue beyond the hospital peak and out the other side of that. So likely to go on towards the end of Feb into March. We are seeing more cases in care homes as well and other residential settings, and clearly the impact of the new variant and its increased transmissibility has been quite a challenge, I think, and really, I guess, had a big impact on how quickly this wave hit us.
Thank you, Ruth. Should we keep going? Going to keep going on testing?
Yep. So just to note that we've now got these 2 sort of types of tests really that are widely available. We've got what we're calling PCR testing, which is where the tests go to a lab, and LFD, which is rapid test, where you get the result in 30 minutes. Generally speaking, the PCR testing is done for people with symptoms, or in some care settings, it's being done as a sort of regular way of just checking whether people have got asymptomatic infection. But in those settings, it's combined with the rapid test as well. So we've got 3 testing centres for people with symptoms in the borough at Brixton, Clapham and Streatham. They are booked on the national portal. Positivity rate has now, it's actually fallen even since I wrote this slide yesterday, to about 21%. So that is still very, very high positivity rate for those sites. In our LFD or rapid testing sites, which is for people without symptoms, our positivity rate is much lower, around 2%. We have got 3 sites currently live in the borough and looking for 2 more sites in the north and the south of the borough to bring those online. They are targeted at people that are still needing to go into work. So they are key workers in effect, but they could be working in supermarkets or in social care or wherever, who don't have access to some sort of occupational testing, and they're encouraged to test at least weekly. But we have testing carrying on in care homes as well, using lateral flow devices and for visitors. Just a quick note on schools to say that the schools do have tests now available there. Originally, there was a plan to test students returning to enable bubbles not to have to be isolated, but that actually has changed today. But there is testing available for teachers up to twice weekly, and there is a plan to also test teachers of primary schools at home, although the date for that to start has not yet been confirmed to my knowledge.
Thank you, Ruth. Just going on to what the impact on health and care services is. So I think we'll start off just with a brief update from the hospitals, but how also primary care and mental health are responding. So I think we got Paran, I think, from the trust perspective.
Yes, thank you very much, Andrew. So from a trust perspective, as you can imagine, this has been a rather difficult time for us. We're certainly facing very higher numbers in this current wave than we did in the first wave. And for us, it's been really important, of course, to get to as many people as quickly as possible. What has been challenged is obviously our critical care capacity. And we've been very fortunate to be able to increase our numbers of critical care to the point that not only do we serve the residents of Lambeth and Southwark and the normal boroughs that would come to particularly St. Thomas's and King's, GSTT has been able to offer some mutual aid to other boroughs within Southeast London to make sure that people can get the timely intervention that's required. In addition to critical care, we've had a number of individuals who've been treated on our general medical wards, and we've had to increase our base from that perspective. But again, it's been very helpful because we've had a number of specialist clinicians, doctors, nurses, therapists, pharmacists, supporting us to be able to provide the best possible care. What we're finding now is that the mutual aid with some of the other boroughs has actually reduced, but there is still a significant pressure, of course, within hospitals because we have a number of individuals who are actually quite unwell or actually supporting towards or needing support for discharge back to the community. Andrew, would you like me to cover the community piece now before I hand over?
Yes, please. Yes. Yep.
Yes, so from a community perspective, as you can imagine, there's quite a significant pressure to get our patients to the right place in the right time. And what I wish to reiterate with this is not done solely from an acute perspective. The only way we've been successful is our ability to work in partnership, both with our GPs as well as our social care practitioners, particularly in order to support a very timely transfer back out into the home environment. And where that hasn't been possible, we've transferred people to more bed-based rehabilitation, but also into care homes. The numbers are quite significant, and as you will know, that people take different lengths of time in order to recover. So not only have we had to create capacity for new referrals into the system, but also enough capacity to keep people safe whilst they've been in the community. A big pressure and a big responsibility and priority we have as health and social care providers is also to avoid any unnecessary attendances within the hospital and unnecessary admissions. And again, together with our GP partners, I think our partnership approach has really helped to support a lot of admission avoidance. So a lot of very active work happening in the independent sector care homes to make sure that people can receive very acute and rapid response care within their current locations, avoiding coming into the emergency department. And even for those who've had to come into the emergency department, we've been able to transfer people back into the community quite quickly to receive ongoing intervention. It's not without challenge, but the systems are in place to support.
Thank you, Perrin. And I think, Andrew, you're going to say a few words on how we've stepped up primary care response. Is that right? Just stay on the back of the previous slide, please.
Yes, I'll kick that off. Therese Fletcher's in the background here as well, I think, and may come in if we need to answer any questions later. But just to emphasise, really building what Perrin's been saying, we have been significantly expanding the services we commissioned from our GP federations and primary care networks in the patch. And certainly the services that we've listed here have been very much mobilised incredibly quickly by our GP federation, who've done a great job of enabling us to step up the support available to our practices and indeed into our hospital system. And some of those are kind of summarized here. So along with expanding some of our existing services, those extended access hubs that people will be aware of across Lambeth at places such as Gracefield Gardens, we've put additional appointments in those services to enable people to get greater access, particularly for face-to-face nurse appointments, but also for patients redirected from 111. And also quite recently significantly expanded the hot zone service, as we call it, for people with COVID-like symptoms at Gracefield Gardens, which has been highly used over the last few weeks. The Federation are now delivering for us a domiciliary phlebotomy service. They're going out and taking blood in people's homes for vulnerable and at-risk patients. We've also recently set up through the Federation a home visiting service for people with COVID symptoms, and also the capability to be able to bring some people back into the hot zone service at the Ackerman where needed. And we're just mobilising some remote monitoring service, as we call them, using technology in a very sort of transformative way, both in care homes, but in particular, the bullet point I missed at the top of the shop there, something called a COVID oximetry service, where through the Federation and through the distribution of certain devices and the use of software, the Federation are able to support people with certain conditions and with certain sort of monitoring certain of those conditions out of hospital and at home, to hopefully keep people away from direct services and away from hospital, but being properly managed and monitored by experienced clinical staff remotely. Really helpful initiative. So huge range of things that have been stepped up, and big thanks to the Federation for that.
Thank you, Andrew. And we'll, on the bottom there, you can see just a few words about how we're sustaining mental health services. We'll come on to much more on mental health in the main meeting. So if we can just go to the next slide. And I think Tom is going to give us just a quick update on what we're doing about what I now call the clinically extremely vulnerable. Previously, that was kind of referred to as shielding residents. Yep. So, Tom.
That's right. Thank you, Andrew. So, yeah, this is the approximately 10,000 clinically extremely vulnerable residents that that we have in Lambeth. So the advice, as for all of us, is for CEV to stay at home as much as possible. We've been in contact with everybody to signpost them to the guidance that they need to follow. That's both the government guidance and also the support that is available to them in the borough. Kind of key front door for that is kind of the My Community Gateway helpline, which is run by AGK, and I've put the details on the slide. So for anybody who wants to call on behalf of a resident, or if you're a CEV yourself or any vulnerable resident, that's the number to call in to get signposted to the range of support that's available in the borough. So that could be kind of food or social support, friendship calls, and so on. The government and we are asking all clinically extremely vulnerable residents to register on the National Shielding Service System. This is whereby this is how they can begin to access priority online shopping slots from the major supermarkets. And I just also wanted to flag the kind of continuation of our on-hand volunteer shopping service, which you can access through the My Community Gateway helpline. So if you're having trouble getting out and getting the supplies that you need, then you can use an on-hand volunteer to do so if you're self-isolating or if you're clinically extremely vulnerable. And also just flag that we're continuing to support the distribution of surplus food across the borough through various community hubs through a commissioned arrangement with the Healthy Living platform. I think that's it for clinically extremely vulnerable.
Thank you, Tom. And just going to the last slide, we hopefully end on a positive note, which is around COVID vaccine. And this really is moving at some pace now across the country and indeed in Lambeth. We've made fantastic progress in the first few weeks. So, as you know, both Guy's and King's and actually the Hurley Clinic in Lambeth were the kind of pilot site, the first out of the blocks for starting to vaccinate people on a nationwide basis. So Lambeth certainly at the front of that. We've now extended that. So all of the hospitals in South East London are now vaccination sites. And we've got coverage for the whole of the Lambeth population from our 4 PCN primary care network sites at the Hurley, Streatham Place, Hetherington and at Paxton Green. And we've got some additional further capacity still to come on stream. So another 2 sites, one at the Oval and Streatham for our PCNs. And also we have a community pharmacy site already gone live this week at Loughborough Junction and a further one planned for Streatham. So we're just within the borough, a massive amount of work now going underway to vaccinate our residents. And as you know, there's a kind of fairly strict priority order that's been set by the national team, starting off with care home staff and residents, but also then with the over 80s, moving and NHS and social care clinical staff, and then moving through to the over 75s, then the over 70s and those clinically vulnerable. So we are moving through those cohorts of populations. Not everywhere is exactly the same pace as we roll out, and as vaccine becomes available, we're doing it as quickly as we can. And by now, all the populations in Lambeth, depending on what age range their PCN is still in, should be getting invitations to come in. Additionally, there's 2 national mass vaccination centres serving the kind of geography of London, one at the Excel Centre, which opened last week, and then one at Wembley, which opened this week. Just on care home staff, so we're really pleased that our PCNs have now offered vaccinations to all residents and staff in care and nursing homes for older people, and we're continuing to roll out to other care homes within the borough. And of course, we're also thinking about how we might also now extend the offer to those who are housebound as we get to use a more flexible variant of the vaccine in terms of the AstraZeneca one. That gives us more flexibility as to how we can actually deliver the vaccinations. As you know, the initial batches had to be delivered from fixed sites. So there's a huge amount of work going on. I know there's some questions we're going to come to in the conversation, which hopefully will answer some of the more detail on that as well. So, Jim, I think we'll probably stop there. There's a huge amount of ground we've just covered, and I'm sure people have got lots of things they wish to raise. Thank you.
Thank you very much to Andrew, Ruth, Tom, Paran. Really useful distillation of, as you say, Andrew, the huge amount that's going on in the borough and beyond the borough fighting COVID at the moment. I'm sure there will be questions. The way I plan to take this is to look to respond to some questions which have been submitted by Lambeth PPGs, grouping together, and were submitted in writing a little earlier today. And then to throw it open for others who may not have submitted questions in advance, but may still wish to ask questions off the back of the presentation or indeed about anything else. Nicola Kingston, I believe you are on the call. What I'm going to suggest, and by all means do it differently if you prefer, you submitted a lot of questions and they are all really excellent and relevant questions. I'm going to suggest that you get a detailed answer to all those questions in writing, but that perhaps because they group into sort of three sections, participation by patients, vaccine rollout, and communications and community, you perhaps ask one question in each of those categories. We give you an answer, and then clearly your more detailed subsidiary and other questions then get an answer in writing subsequently. If that sounds all right, I'm going to invite you, Nicola, or indeed others from the sort of PPGs that were part of the questions that Nicola submitted, to come in and ask a question in each of those three areas. So, Nicola.
Thank you very much, and that sounds fine. And yes, if Jane or...
We've lost you, Nicola. Thank you.
First of all, I just want to say huge congratulations to everyone. And I think, you know, it's amazing the amount of work that's going in. And we are deeply, deeply grateful to everyone for all the incredible work that's going on. In the PPG, I mean, my one, we've been very much involved in Brixton and Clapham Park. And we know the amount of work that's been put in, and so pleased with the co-production. We've been working with the LPPG network, and we've been working with Citizens UK and doing an enormous amount of listening. And we've had a fantastic video that they put together working with us, and we've got more to come. So we want to be very much part of helping as we go forward, and we're so aware of the inequalities that are around at present. So the first one is, will you be supporting patients in each PCN to be involved and to sort out the feedback? The second one, I think we would be talking about the variations in the vaccine rollout, that lots of people are very, very anxious because they haven't heard. And then there are some people who have been lucky enough to get through to the hotlines from the hospitals. So they've been vaccinated in advance of some of their neighbours and friends, and are feeling anxious about that, and very much aware that it's tended to go through things like tennis clubs, for example, which may not be open to all. And I think the third one is really about making sure that we have local voices working on local solutions. And I think Owen will be talking later maybe about that in particular. But I think we're thinking too about how do we reassure people who have not heard yet about the vaccine rollout, And certainly our PCN have been doing some very good text messages out to people. But it would be good if that could add in a note of reassurance that even though you haven't heard yet, there is a priority order. We can talk to you in more detail, and some of your PPGs will be able to help that because we know you won't have staff the time to explain all that. But if you give it to voluntary sector people, PPGs and faith communities, for example, we could help on the messaging. Thank you.
Thank you very much indeed, Nicola. Three really relevant and extremely helpful questions. I'm going to pass those over in their three sections to Andrew, Ruth, Adrian, and others. Andrew, did you want to kick off with the issue about supporting patients to be sort of part of the decision conversation that leads up to the way in which we run the operation in the borough?
Yeah, actually, Jim, I think I'm going to ask Adrian to respond first, because he's been actually doing that in his own PCN, in his own practice, and they went live this week, as Nicola suggested. But absolutely, we'd want people to be involved, and we want to hear the feedback. But I think it'd be good to hear it from Adrian, who's actually on the front line, been vaccinating this last weekend, and has been part of the design in at least one part of the borough. Adrian.
Brilliant.
Thank you. Happy to receive the pass. And I think very gratifying to hear the sort of the positive feedback, Nicola, and thank you. And clearly, you have some familiarity with my patch as well as a sort of more general question. And the one thing I would add to that is, it has felt a hugely positive experience being part of it. And my sense is that all those involved in delivering the vaccine, putting the plans in place to receive it, and receiving the vaccine, and this has felt enormously positive. And I think the questions you raise are about maybe those who've not yet got to that point of receiving it and being able to feel that. And it may be something, and how much of these sort of different questions to pick up directly together, because I think they do all wrap together. I think there's clearly a theme running through this, and we have a well set up arrangements, but I think by the nature of the vaccine, the delivery, and the way it's been managed, I think from the start it was not possible to spread this thinly, and so the fact that we've had to manage with vaccine, the Pfizer vaccine, meant that it could start only at a small number of sites and roll out, and I think that's been the experience, as well as the national drive on who and how should be receiving it. And I think we're doing our best now as it scales up to make sure that is evened out and levelled up as quickly as possible, and that clearly is joint working in doing that. And that's probably enough to say in terms of that. I mean, is it worth picking things up more directly and passing it around? Because I think the important thing to recognise now is how we move, both in getting the best spread across the borough geographically, and the most appropriate kind of prioritisation within the national guidance in who is getting it. And I think the progress on that has been fabulous. I'm happy to kind of pick up later maybe a bit about how we've got to the places we've got and the processes that we have.
Thank you very much, Adrian. Perhaps I could ask Andrew or Ruth to come in with a very relevant question around vaccine rollout and differential take-up, and the work we're doing to make sure that parts of the community don't miss out. So, Andrew, over to you, and then perhaps to Ruth.
Yeah, shall I start? So we're kind of working at different tiers on this. So South East London have been doing a lot of work around the kind of standard messaging and how we get the right kind of information and Q&As and all that kind of stuff around the content of the vaccine and how it's applicable, all those kind of things to give the real facts out. And then secondly, the other bit is particularly at a borough level, is to think about, well, who are the people that can get those messages out most effectively, and how can we reach into the communities that need it most? So what we've been doing over it's a shame Catherine hasn't been able to get on. I know she's struggling to get in to the meeting, but so Health Watch have been running some sessions. We're working with our community champions we've been working across South East London, but then locally with our faith leaders and with our third sector, and whether it's through local sessions or South East London ones that have been very well attended by Lambeth leaders, bringing those messages back into our local areas and into the borough. So that's the kind of stuff we've been seeing. You've also seen a range of videos that people have been producing. I think you mentioned, Nicola, the one that had been done in Adrian's patch, but Stockwell Partnership have done one in part in Portuguese. Di Aiken is on the call, has done one, and we've been encouraging our councillors, and in fact Jim and Ruth and I met with a whole raft of Lambeth councillors yesterday, and encouraging them to start to produce videos that will get out into their residents and their wards, and that we can use on a very local basis. So the point about getting out to people is a really fundamental one, in finding not just the right content, but the right people that can have the biggest impact with those messages as well. And we're just pulling together over the next week a kind of consolidation of those approaches. We have, we've agreed a set of principles will apply. We're asking the local authority comms team to lead on it rather than it being the NHS, but drawing on the kind of valued input of clinicians wherever we can as well. So there's a whole raft of stuff going on, and obviously it's been quite tricky to message some of this stuff in the very early days, given the differential rollout and the kind of changing policy. But I think two things are really important in the stuff we've just covered. One is we now have whole Lambeth coverage. So in a sense, we can, there's no bits of Lambeth that are excluded from being invited in now, even if they're at slightly different points in the rollout, but that should quicken up pretty quickly. And the second is the provision of the AstraZeneca vaccine, which allows us to deliver from more places, and therefore to give more flexibility as to how we deliver. And if those two things are coupled with a greater supply of vaccine into the borough, then the kind of pace at which we move will really increase. And I think we're fairly confident that we will meet the kind of mid-February target that was set us of getting through the first 4 groups of priority populations. So the stuff about are people excluded to date and so on, in terms of being invited at least, that should all be cleared through by the middle of February. That then leaves us the issue about those people who are more hesitant about the vaccine, and how can we work really creatively to kind of get them the right messages, and work with their own community leaders to think about how we can persuade people to take that up. But I'll perhaps pass on to Ruth, and she might be able to kind of give a perspective from public health as well.
Yeah, Catherine's got her hand up as well, so she's got in. But just very briefly, I'll just say that we're absolutely aware of the sort of risk of a real inequality being set up here, and understanding what's happening in our data, and making sure that we both look at some of the barriers. Some of those are actual barriers probably to getting vaccinated, so understanding what they are, as well as the vaccine hesitancy issue. Lots of work going on with council comms, working really closely with NHS comms around our messaging, but most importantly working with communities to understand those issues and how we need to address them. And that's at every level, very, very local, but also up to borough, South East London, London and national, because there are bits of the country where they've done amazing work actually that we can really learn from in London in particular communities. And I think we've got people from the trusts on the call now. It's probably a bit short of time, but understanding some of their experience with staff is really helpful, because their staff are drawn from our communities. So that's a really useful bit of learning that we need to apply locally. And just spoiler alert, Health and Wellbeing Board will have a thing on vaccination as well. So we'll bring some of this into that space. That's on the 11th of February. So we'll be a little bit further in, and hopefully have a bit more of an overview of what's happening on the ground at that point, and what further work we need to do. But maybe if we bring in Catherine as well.
Yes, Catherine, I'm glad you've been able to join us. Sorry about the problems you had getting into the call. Did you want to add some of the work that Health Watch have been doing?
Yes, a couple of things. I wanted to say that from the Health Watch perspective, and I'm sure it's the same with the patient groups, we really value the way professionals within the system, clinical professionals, have made themselves available. And early feedback from the webinar we had an hour ago is that people really enjoyed speaking to Avi as the chief nurse and learning from her experience. And it's about those trusted people giving honest answers that really convinces people. We're also very pleased that guys are letting us speak with their learning disability nurses for our seminar next week, which will be a closed one for adults with learning disabilities. So it's trying to find all these different ways of talking, keeping the conversation going. And just to support what Nicola was saying, I think the other thing to recognise is how fantastic the Team Lambeth volunteers are. When Therese first put out a call for volunteer support, it went through that system so well, the system was well set up, and people were coming forward within minutes to offer to help. So just to say, we've got another asset there with those volunteers that we can use.
Thank you very much, Catherine. Just on the third question, I mean, I suspect that what we've said under the second question to some extent answers the third question, which was how we are going to engage with the community to make sure, in a sense, the system and the community work hand in hand on these issues. I hope that some of the responses that have been provided around the way in which the whole system will be mobilising local communities, people like the Project Smith connectors, the BCS, faith leaders, other community organisations to work with us around COVID rollout and make sure there isn't this potential disparity that some of the polling and some of the attitudes that we hear and some of the anecdotes we pick up indicates that there might be. It's really a #1 priority in terms of the communications and engagement to make sure that isn't the case and that everybody gets vaccinated and that we have kind of community immunisation. I hope that answers your third question, Nicola, but obviously we'll give you a detailed written response as well. Could I just quickly ask whether there is anybody else who wants to come in with a question at all? And depending on whether there is, then Nicola, I'll be very happy for you to sort of come back with a response to what you've heard if you wish to. Does anybody wish to stick their hand up in the chat and ask a question?
Jim, it might be helpful to pick up Sarah's question in the chat. So she's asking about have we got the data on ethnicity? Because I do think that directly goes to the points Nicola's making as well. We don't yet, and we are really desperate to get hold of that data. So we really want to get the data out of the national system, particularly for those people who've been vaccinated by the trusts and the mass vaccination centres, as opposed to the PCNs, where we do have some access to that, so that we can start to analyse that data without delay, so that as we roll through, we can really understand where we're getting good traction with the take-up and where we need to focus our efforts. We're making assumptions at the moment as to what the outcome of some of that data will be, and that's probably accurate, but the extent to which we're right or wrong is the bit we're not quite sure about. So we are keen to get on that. We're trying to find some workarounds through our general practice systems. We've not been able to crack that yet in terms of the relationship to the national system, but hopefully we would hope to be able to do it pretty quickly. So an important question, and one we're working on still.
Thank you very much, Andrew. And just while you mentioned the material in the chat, there's lots of very good stuff being posted at the moment. So, for instance, some of the videos and other materials that have been produced are there, as well as a guide to going on the main South East London site, where you can find a whole bundle of very useful resources which provide information about what's being done and provide messaging which people on this call and outside can use with community audiences in order to let people know what's happening. So I've got 3 hands up, so let's go to those. So I've got Owen, followed by Gay, followed by Susan. So Owen, would you like to ask a question? Owen, I can see that you've got your hand up, but I can see your microphone is also muted. So you may be trying to ask us something, but we're not hearing you.
Am I okay now? Can you hear me now?
You are. We can hear you. Thank you.
First, can I just echo what Nicola said and thank all the folk who've been helping so much. My wife and I both had COVID in November, and it was a very frightening especially for my wife, but we had absolutely marvellous support from Clapham Park practice. So thank you personally, but thank you generally. The question I wanted to ask was that you partly answered the question about getting the message out to hard to reach people, but it's partly a problem of remoteness. I mean, the place where I will have to go for my vaccination is nearly 4 miles away. I can cycle there, but there are a lot of people who are frightened to use public transport, and it would be really helpful for the hard to reach people if it was possible to ensure that the vaccination sites were much closer to home, ideally in their own GP practices. I mean, I obviously understand there are practical reasons why the Pfizer vaccine doesn't allow for that, but I think in terms of take up, especially for the enormously promoted if we can get vaccination sites into every PCN area. Thanks.
I'll mute Jim.
Thank you. I'm doing the same as everyone this afternoon. Really useful question. So I'll ask Ruth, Andrew and others to come back, but we'll just get Gay and Susan's questions first and we'll come back to them all at once. So Gay.
Can you hear me all right? I'm having difficulty unmuting.
Yes, I can hear you, Gay.
Mistake. I didn't mean to put my hand up, so please ignore me. Sorry, apologies.
Okay, no problem. I'll go to Susan.
Okay, can you hear me?
Yes, we can, Susan.
Okay. All right, I just want to say thank you as well, and just to say that my vaccination at Hurley Clinic went very smoothly and was a very positive experience. I've got a question about test and trace, national test and trace, which I'm aware obviously is not within your control, but it does impact the context that you're working on. And according to the latest weekly statistics on test and trace, the median number of contacts supplied by people who've tested positive and who've been reached by test and trace is 2. And the vast majority of these, over 80%, are from within the person's own household or dwelling. To a layperson like me, that seems like a very low number. So I wanted to ask, probably Ruth, whether the system working like this is sufficient or adequate in terms of interrupting transmission. And is the low number likely to be due to reluctance to identify contacts outside the household who would then be required to self-isolate? And I suppose finally, quick question, what could be done about it?
Thank you, Susan. Great question. Ruth is very much across these issues, both because we've been running our own tracing operation in Lambeth, but also because she's been having, through that process, to deal with national test and trace very extensively. So I'm sure she can come back to you on that. Andrew, did you want to deal with the issue about locality of the vaccine rollout first?
Yeah, so it's a very good point, and we would like to make the vaccines as accessible as possible, which is why we've now got 4 sites with a further 2 rolling out, and then the pharmacy sites as well. So we would like to make them available as close to people's homes as possible. And then of course there are those people who are housebound, and we are looking to see how we can create a service that could visit people in their own homes, but that will be for the housebound as opposed to those who can get out. So you're absolutely right. What we're trying to do is balance, though, if you like, the operational realities of the vaccine delivery and where you put staff and support for people, because obviously you need vaccinators and so on, and you need to do it at some scale with being as accessible as possible. So as the amount of vaccine becomes available to us increases, we'll keep that completely under review and try and get the right balance of access and particularly make sure that sites are accessible in terms of transport links, recognizing the fact that people are very nervous about going out, particularly in the older population cohorts. So I don't know, Therese, or Adrian, if there's any more you'd want to say about beyond the initial plans, but that's kind of where we're at the moment, I think, isn't it?
Just while perhaps Adrian is thinking about that, I'm assuming he doesn't want to add, because I think that's a good summary, Andrew. So over to Ruth. Sorry, Adrian, did you want to come in on that?
Oh, no, I think that's very helpful, and very happy to kind of go through the process that's got to the sites that we do have at the moment, which has been absolutely a kind of collaborative endeavour to try and make sure that we are choosing fairly to make it as well distributed as possible and as effective as possible.
Thank you very much. I'm going to go over to Ruth now to answer the question about national test and trace efficacy and what we can do to make it more effective.
Yeah, thank you. So the median number of contacts being around 2 is, to be honest, not far off what it has been. I mean, ideally, if people are following the advice and staying at home, then you would expect them to have fairly low numbers of contacts, and most transmission does occur in households. There's sort of really quite good evidence for that now. But obviously it does lead to the question, if you only have a mix with your household, where do you get COVID from in the first place? So there's clearly something else going on in that. And that may well also be linked to the increased transmissibility we've seen with new variant as well. So settings that were probably very, very low transmission may have slightly increased over time as a result of that. We think that locally we can get access to more people through our local test and trace, and there's certainly evidence that since we've been doing it, the numbers have gone up in terms of the people we reach. But we are definitely picking up that there are barriers. And those barriers tend to be people don't want to name people as contacts because it does mean they have to self-isolate, and if they are then dependent on an income and they can't work as a result of it, all of those things have impacts. And one thing that we can do locally is when we contact people, we try and ensure that they're aware of the financial support that's available to them, and also that actually the contacts will get that support if they name them and they're linked, but they won't get it otherwise. So it's actually better in many ways for people to name those contacts, because they can then access financial support in a way they wouldn't be able to if they're not a named contact. Increasingly, we're also we get data now of where people sort of say they've been in the period before they picked up their infection or tested positive. So that enables us to do a bit of what we call sort of reversed contact tracing, to see if there are particular areas, places which are implicated in transmission, and then we can work with businesses or those settings to see if there is more we need to do to make them safer, or whether there's a particular event or something that happened which may well be implicated in some of that transmission. So it's sort of a range of different things, I think, rather than one single thing that actually makes a difference to contact tracing. And the real advantage of doing it locally is that you have local people that understand the geography and how people work and travel around your borough in a way that if calls are diverted all over the country, you don't necessarily build that same picture. So we are recruiting to one of the real challenges we had after Christmas is the case rates went up so much. We went from getting sort of 10 cases a day to getting hundreds literally of cases a day. So the capacity to manage that and respond has been quite challenging. But we have recruited to a core team of contact tracers, and we are able to augment that with our own staff as well, so that if we have surges in our requirement to step up contact tracing, we'll be able to do that. And hopefully what it means is longer term, we'll be able to take more and more cases from the national system, because at the moment the national system for the first 8 hours holds on to those cases, and then we get them if they don't contact them or they don't make contact after 8 hours. So it will enable us to do a bit more work in that regard. But there will always be people we miss, so we're looking for ways to try and make sure that we do get those people, particularly those that might need support to self-isolate, because that's a critical thing here. That's what will stop the transmission, enabling people to self-isolate.
Thank you very much, Ruth. Thank you for the question, Susan. Just one quick thing to add. It was very gratifying to see on a Newsnight survey last night of those councils which have been able to use their discretionary funding in order to support people to self-isolate. Lambeth was at the top of the lead for acceptance of claims for payments for people at 77%. There were other parts of the country where that was well below 50%. It was being described as a postcode lottery, and I hope by living in Lambeth, perhaps you've won the lottery, if not feeling like you've won the lottery, but at least you're being supported to self-isolate, which I think is really important. I've seen one more hand up. We are beyond the 20 to 3 time limit, but because it's Sarah and she's got a hand up, I'm going to invite her to ask a quick question.
Yes, thanks. I'll be quick, and you may want to answer it in another way, not at this meeting. It's about a parallel issue, which is about clinic appointments that are taking place at the moment. I'm sure that a lot of these have gone to virtual, telephone, and so on. But I think there are still some happening in person, and for obvious reasons, you know, you're encouraged or only allowed to bring yourself, unless you're caring for somebody with dementia or a child. So all that makes a lot of sense. But I've been asked around about an issue where somebody has a life-threatening diagnosis and is making big decisions about treatment and care, and the fact that a carer or partner is not able to attend to participate in that discussion. And I'm just wondering, really, if there are sort of more creative ways and that could be made to work to enable the carer or partner to be part of that conversation and not be sort of waiting in the car park for the person and not really knowing what's going on. So as I say, it might be a question to think about outside the meeting, but in terms of quality of life and the importance of that decision-making process for cancer diagnosis and so on, I think it's something we would be very helpful to think about. Thanks.
Thank you very much. Thank you, Sarah. Perhaps I'll pass that over to Andrew for an initial response, and if it does require a follow-up, then I'm sure he'll make sure that happens. Andrew.
You're on mute.
You're on mute, Andrew. I'm afraid the disease is catching.
There's at least one every meeting. Sarah, can I just be clear? Are you talking about appointments to hospital or in general practice or both? Or is it general?
I'm actually, in this case, I'm talking about hospital appointments.
Yeah. Okay. So I think what would be helpful if we kind of went back and perhaps had a conversation with Parren and our colleagues just about the extent to which people are now invited in. So I know that they're very anxious not to bring people onto the hospital site because of the risks, obviously, of infection and cross-infection and so on. But I hear the comments you made. Can I go back and try and get a better answer to that than I can offer kind of off the cuff? And I think it might be different for different specialities and different services. So perhaps if we come back to you, I think that might be a better way of giving that answer.
Okay, that's fine. Thanks very much.
You're on mute now, Jim.
I'm going to permanently mute myself in a minute because I'm handing over to Andrew for the next bit of the meeting. But just to say thank you for those questions. Really important points raised. We will get fuller answers to those that were made in writing. There will be lots of opportunities to interface with the system going forward on the way in which COVID, but all other health and care issues are being managed. And as was mentioned, the Health and Wellbeing Board on the 11th will be having a full discussion about vaccine rollout, and we'd welcome people who are here, but obviously all residents and others across the borough to join us in that conversation. So I'm going to hand over to Andrew now for the rest of the meeting in public.
Thank you, Jim. I'm going to move us on very swiftly because we have cut down the time. Thank you for Wendy for your comment in the chat about keeping the public forum going, but we have cut down the overall time available to us. So, and also the scope of the agenda, but it is important we give enough time to those items. So welcome everyone to the meeting of the Lambeth Together Strategic Board. I'm just going to check that there are no declarations of interest that board members wish to make that they haven't previously included on the register. I'll take silence as that's okay. And I'm just going to check whether anyone has any comments on the minutes of the meeting of the 18th of November. Again, if you have any comments, could you perhaps put your hand up in the chat?
I was there at the last meeting.
Okay, thank you. Thank you, Raj. We will add your name to the attendance list. And then Sue, I think you've put your hand up as well.
Thank you, Andrew. Could you add my name to the attendance list too, please?
Yes, apologies to both of you for omitting those.
I just wanted to ask 2 questions, if I might, on as matters arising.
Of course.
The first one was, have we managed to improve upon the 86% of children with education, health and care plans attending school? And the second question was, are we able to cope with the increase in domestic violence and the need for safe houses? And have we been able to put any more funding into that?
Okay, I'm going to initially turn to Abby to see if she's got an initial response to that, but I suspect we might need to come back in writing on those two questions, Sue. So Abby, I don't know if you've got a kind of initial response for now.
Hi, afternoon, Sue. I'm going to have to come back to you on the response in terms of the education, health and care plans, and I'll put that in writing. In relation to the domestic abuse, so I can respond to that partially, and then I'll complete it in. Hopefully, you guys can hear me. My thing is very low. So there is refuge provision that's being provided, and that's still being provided by Gaia. There has been some kind of wider national guidance in terms of support for anyone who is at risk of domestic violence and abuse, and I'm happy to share that in more detail and in some writing. And we are currently looking at our kind of wider strategies during this lockdown, alongside some of our provision, to make sure that our delivery is safe. So we're risk assessing those who are in our provision, and also risk assessing those who are exiting, and making sure that we are working closely with the front doors of various services to make sure that we're still having sight. And I think hopefully you would have all seen on Twitter that there's a massive campaign at the moment so that we can continue to alert people to make sure that they are making themselves present and known. And there is a wider campaign nationally in terms of for those who are fleeing violence, how they identify in public spaces. So I'm happy to put it in writing so you can have a lot more detail than that.
Thank you, Abby. And I think Ed put his hand up probably to add to that.
Yeah, it was just on the EH, the children on care, education and health care plans attending school. Abby will get you the precise data, but I know obviously primaries and secondaries this term have not been open to all children, only to key worker children and vulnerable children. The snapshot data I saw from last week was it was only about 10% of the normal, as in in a normal school year, attendance of children, and of those, which was nearly 3,000 children in Lambeth, about 2/3 actually attending school were key worker children, and 1/3 were vulnerable children, which includes the children you mentioned, Sue, but also other ones. So there's a sort of disproportionality, I would say, around we're getting lots of key worker children or more key worker children and less vulnerable children than we would like. But that's how it was in the summer, and we tend to get more vulnerable children than the national average, although that's still a very low number. So it's not where we would like it to be. Obviously people are concerned and worried and keeping their children at home, but yeah, Abby can get you more details on that.
Okay. Thank you to both. If people are happy, we move on to the substantive agenda items? Is that okay? In which case, can I hand on to Guy and David, who are going to give us the update on the work of the Lambeth Well Alliance, and particularly reflecting on the kind of review and the report they pulled together. We thought it was important, if you remember last time, that we gave that some substantial time here at the Strategic Board. So I'm going to hand over to Guy and David.
Thanks, Andrew. In fact, my colleague Sabrina is going to introduce the presentation.
Thanks, apologies, Sabrina. I was working off the agenda.
That's okay, Andrew. Thanks for inviting us to give an update on the work that we're doing. This afternoon, myself and colleagues will go through for the next 20 minutes, give an overview of some of our successes and challenges that we've had. We'll also ask the board to support our community mental health transformation bid that will be submitted today. We'll also have our GP colleagues as well as consultant psychiatrists talking about the Lambeth Staying Well prototype that's occurring and their role in it. And colleagues from Black Thrive and a service user will also talk about the development that we're doing in terms of developing a culturally appropriate peer support and advocacy service. And we'll end with a video from Mosaic Clubhouse, which is one of our key network providers. So without further ado, I'll pass you on to Guy, who'll give you an overview of our successes and challenges.
Thanks very much, Sabrina. And this is a very quick summary. I'm just going to shoot through this. Much more detail in our progress report, which was on the previous slide. I'll make sure there's a link in the chat in a moment. So we've basically spent our first 2 years really putting together our structures and our services to address the issues that you have raised, that people have raised with us. And we've been working with the people we support and their carers to design new services. So we've created a new crisis outreach service. We've created a new front door because people are saying they fed up being passed from pillar to post from different teams and repeating their stories. And we've really joined up our support. So we brought together clinical people, social care people, and voluntary sector colleagues all together in joined up teams. And there is a slide later on that will just show you that, and hopefully you'll get the pack and you'll be able to see that. So that's a really quick run through of our successes, and it is really about addressing the issues that you have raised, your concerns about mental health services in Lambeth. But we've got lots of challenges ahead, and just looking at the next slide, please, Cheryl. Thank you. Clearly, we're in the midst of COVID. That's really affecting everybody, including us, and we've got more staff ill at the moment. However, we're keeping all our services running. All our services are open and remain open. Sometimes we're having to deal with obviously more people virtually and by telephone and so forth, but our services are still open. We continue to have financial challenges. Historically, as you know, mental health has been underfunded, and I'm pleased to say that we've had significant more investment in mental health services in Lambeth in the last couple of years, and that's helped us to build some of these new things that I've mentioned and we talk more about in the report. One of our big challenges, of course, is inequalities, and it's only been emphasised more by the current situation, and we've heard about some of those issues. We're working on with our colleagues in Black Thrive on a culturally appropriate development of our services, and you'll hear more about our colleagues in a few minutes' time, which is why I don't want to spend too much time on this. So that's really a very quick run through. Please try and get a look at the progress report. It's on the Lambeth Together website. I'll put a link into the chat room, and obviously happy to try and answer any questions later on. So I'll hand back to Sabrina. Thank you.
I'm on mute. Thanks, Guy. Cheryl, if you could move forward a couple slides for us. Thanks. So this, in a nutshell, is our community transformation bid that we're asking for support for. As Guy said, we've been lucky to get investment in mental health, and in the next 3 years, we're due to have even more investment. And we've worked with partners to come up with what we think would help to bolster our current community offer. And we'd like to develop more our peer support offer within a reablement offer within the community, and also to work more with our GP colleagues by looking at the mind and body and ensuring that we've got some workers in that field. So as I said, what we're asking for the board is support for this bid that is going in today as part of our SCL CCG offer. I'll hand over to colleagues Nozomi and Jenny and Sumitra to talk about our Staying Well prototype.
Hi, do you want to go into
No.
Do you want
I will do. Is that Jenny? Hi.
Yeah, you go first, Nozomi. You go.
Hi, I'm Nozomi Akanuma. I'm one of the consultant psychiatrists in SLAM, and also I'm Associate Medical Director for Lambeth. So this is the model we have already established within the Living Well Center, Living Well Network Alliance. As you can see, the orange bits within the Living Well centers. There are 3 in the community. And there are blue circles, which are services we have already established within secondary care or entry to the secondary care mental health services. It's so clear that we don't have much at the moment to cover the primary care aspect of mental health services or bridging between. Please move on to the next slide. I will skip this. So could you move on? So staying well is always our aspiration to develop from the start of this Living Well Network Alliance model of the mental health care, providing from the prevention and primary care and secondary care onward. So our plan to develop this Staying Well service or Staying Well offers have encountered a lot of challenges, and the most recent one is obviously COVID one. However, the more we developed the secondary care services in the mental health within the Living Well centers, we realized that something more. We have to start as early as possible. So this is the product of our committed, shared commitment to develop something despite the challenges and despite the uncertainties of the funding coming through. So a small group of GP surgeries and PCNs in the north locality, and also a group of us from the secondary care got together in the autumn and started some discussion to develop some prototype. And 2 PCNs from the north locality and us started 2 pilots initially for 6 weeks to test out some models. So the main goals are to develop some model that primary care and the secondary care practitioners, not only from the statutory services like GPs and psychiatrists and professionals, but also social prescribers, pharmacists, and support workers. And the initial 6 weeks were used to set up this model. And the initial reception was really good. So we decided to extend it to March. So I will pass this to Jenny, who actually was one of the main drivers of this prototype. And I don't know if Sumitra is here. So Sumitra is a consultant psychiatrist coming from our way to run this jointly. So passing it to Jenny.
Hi, I'm Jenny Parker. I'm a GP at Hetherington Group Practice and the clinical director of the Brixton and Clapham Primary Care Network. We were one of the 2 networks that have been piloting this prototype. And I guess just to say what this means for us day to day in practice. So it means that once a month from each practice, you've got a way of connecting with those in our mental health team sort of colleagues. For patients, this means that I can speak to a patient and know that if they're struggling or if there's an issue and it's not super urgent and I don't think that they need urgent referral, that I've got a way that I can contact, speak to colleagues, and we can work out the best way for them. And I think this stops them bouncing around the system. Sometimes it will mean that they do need referral. Sometimes we'll get medication advice. Sometimes, because we've got a multidisciplinary team in the meeting, our social prescriber will say she knows of a local service that is working. That's been particularly relevant in COVID times because the services have been changing all the time. And even sort of services like Mosaic, it's been difficult for us to keep track when they're open and closed. So having that knowledge has been really helpful. And it's also been really helpful personally for me. I've learned a lot about what social care packages are available for our patients and when they're at the max or what to expect. So I think really on the ground that has made a difference. And so although a patient themselves wouldn't necessarily sort of be in the consultation, as it were, we can discuss and as a group find out what the most appropriate way forward is for them. And that's been very positive. And we can also take away learning from this. So particularly medication changes and things, once you've done that advice a couple of times, it will stick within practices. I know I'm not meant to talk for long, so I will stop there. I think there might be another slide, actually. I don't know if you want to go on to the next slide. Oh, no, that's it on Staying Well. I think Sumitra was going to join, but I know he's in a virtual clinic, so I don't think he can join.
Great, thanks,
Just
Jen.
just a final word from me. So this, for the patients and other people in the community may not see what we are actually doing, because we don't directly involve patients necessarily for the consultation or carers. But this is our goal, or what we would like to achieve from this is that patients don't have to move. We can set up something so that we can provide necessary cares wherever patients are there. So that's the goal.
Thanks, Ms. Omi. And I'll hand over to Shola from Blackfriars to talk us through the culturally appropriate peer support and advocacy.
Hello, hopefully you can all hear me.
Yes, we can.
Excellent, thank you. Okay, so the cultural appropriate peer support and advocacy service has been something that we've been working at Black Thrive in collaboration with the Living Will Network, and basically was a response to really thinking about how we can improve and the support for people's mental health and well-being, using, in particular, looking at the Black communities. And what we have been doing over the last 5 months is thinking about how we can reach out to the community and make sure that they are central to the service that we develop. Because we wanted to ensure that the peer support service was really focusing on, the recovery process, but also acknowledging the inherent challenges in relation to racism and how we know that the negative impact that it has for Black communities when they are trying to access services or their entry points into mental health services and the care that they receive. So we've been in the design process, and initially we went out in the pre-discovery phase really to think about the goals and the initial indicators of success as defined by the community more widely. And at the moment we're in the discovery phase, which is basically just trying to make sense of those initial insights and explore them a bit more to find out about unmet needs, gaps and opportunities. And we're looking at this from not just the service user perspective, but from carers, existing peer support workers as well. Then we'll move into the define phase, which we're starting to kind of look at as we are collecting the data, but obviously it's been very difficult reaching out to the community and hearing the different voices and the narratives and the stories given the current situation that we're in. So that has been a little bit slower, but we're starting to kind of make sense of what does this mean for our service, what does it look like, what will our offer be? And then part of that will be identifying the appropriate training content for our peer support workers and advocates, and finally in the deliver phase launching a CAPSA offer. So I know we've not got long this afternoon, but if we move on to the next slide, it gives an opportunity for you to kind of, or for us to kind of see what's being said. Are you able to move on for me, Sabrina? Thank you. So initially, as I said, we had 2 community engagement sessions held virtually. And during that, we really wanted to explore what culturally appropriate means. And that's not a question that's easy to answer. But I think that the consensus is that for members of the Black communities, it's quite apparent to them what is culturally appropriate. And I think there's something very central about really just understanding the cultural values for the community and what that means to individuals. And there will be an overlap. Not every member of the Black community will have exactly the same culture. There will be variations, but the values will be quite stable. So we've been exploring that, but also looking at what Black communities want from mental health services. We can get an understanding of what they're receiving, but actually what do they want, how do they want it, and that being really a key question that we want to understand in order to kind of not just go and create something again that's not really meeting their needs. And also filling the gaps in knowledge about what's known and unknown in relation to mental health services and the support that they can be offered, and thinking about those types of issues. And I mean, just underneath, there's some quotes here that really in relation to how, as I say, it's Black communities plural, in that there are many different backgrounds and beliefs, but there's something about the cultural capital and cultural value that should be understood by organisations and people supporting people with mental health problems from the Black communities, and also just being really open to understanding how the social issues will impact on people and the difficulties that they're experiencing, and wanting to see greater representation within services and to be able to relate and just be treated with respect, fairly and equally, and not on the basis of their colour. And then finally, if you can move to the next slide for me, Sabrina. As I said, we're straddling the kind of define and develop stage, and to help us with that, we have a service user working group. Unfortunately, the service user that we hope to join today, just to deliver a little bit of this, it was unable to make this time. So, but what we have done is kind of recruited members of the community who are skilled in terms of they have research skills and expertise, but more importantly they also have that lived experience, and they are helping us in the co-design and activities that we are undertaking. So from carrying out and conducting the research with individual participants to actually contributing to the model development. So every step of the stage is making sure that the co-production of the service, or the co-design of the service, is done in tandem with service users as well. And as I say, the last few things in relation to, I've touched on peer support and advocacy recruitment. We'll be looking to think about how we can do that more widely in the community, and think of the best model to suit the needs. So, and they will be obviously trained. So looking at what training would really help the peer support workers and advocates undertake the necessary roles and responsibilities. And all this work is actually tying into existing, well, not existing, but other initiatives that are currently running in terms of the patient and carers race equality framework. And so the community engagement that they're doing there, we're helping to support that. And also, this is the kind of pilot for the inpatient care model that SLAM are focusing on in terms of the new site that's being developed. So I think that's probably given a good overview of what we've been up to.
Great, thanks, Shola. And thanks, guys. Andrew, do we have time to show the video?
Just remind me how long it is. It's about 3 minutes. Is that right?
6 minutes. 43 seconds.
Can I make a suggestion? Can we go to questions, and then perhaps we show the video at the end for people who can hang on at the end of the meeting? Would that make sense to people? Because some people might need to get away, and I don't want to lose the equalities item. So what we'll do is we'll have it as a kind of leaving piece, and then people can hang on and watch it if they wish.
Okay, and we can put the link in the chat as well.
Exactly. Yeah. Sabrina, is there anything else you wanted to present today, or anyone else to speak?
Well, I think that's it. It was a whistle stop.
That's fine. It's
a
fantastic amount of ground covered. And what is fantastic is to hear how much is going on, despite having to then adapt also to the challenges of COVID in the background as well. And obviously, mental health is the mental health response is critical at this time. But to actually do such an amount of developmental work alongside the kind of more immediate requirements, I think is fantastic. But let's just throw it open to questions. I see I've got 3 already, so I've got Ed, and then David, and then Sue.
Thanks very much. That was really, really useful, and it's wonderful to see the sort of Black Thrive work with us taking real shape and developing. And I was sort of co-chair of the Lambeth Black Health and Wellbeing Commission however many years ago it was now, that sort of helped lead to the development of Black Thrive and some of this work. And I was doing some slides earlier, and I was talking about the disproportionality of our Black residents in secure psychiatric accommodation being about 70%, or was back then when we did the report, as opposed to about 25% of our general population. I'm not necessarily expecting you to be on the numbers now, but it would be quite useful to get that. What's the disproportionality in that like these days? Hopefully we've shifted it a bit, but maybe not very much. I'm not sure, because I know we still have very high sections under the Mental Health Act. And from memory, I think we've basically kept a lid on acute admissions whilst other boroughs have gone up a bit, even if we haven't cut them. But perhaps you could just talk about that, because that's some kind of indication of whether our new approach, which seems like the right one, is having some kind of effect on keeping acute admissions down.
Thank you, Ed. I'm going to suggest we take the 3 questions and then come back and deal with them in one go. So David next. David?
Apologies to lift my mic off. Mine wasn't a question, it was just to kind of a follow-on to the presentation, just to highlight the fact that there is the consultation going on in relation to the white paper proposals in relation to the Mental Health Act, and the Living Well Network Alliance is going to kind of be, on behalf of the Lambeth Together Partnership, is going to be pulling together our partnership response to that. So we'll be kind of consulting with some key partners, including Black Thrive, in relation to that area of work.
Thank you, David. And then Sue, and can I just check, is someone sharing their screen? I can see someone's.
I think it's Nicola.
I think it's Nicola. We can see your inbox, Nicola. Do you want us to see your inbox? I don't know. Is there any way we can put the slides back up? While we try that, Sue, what's your question?
Thank you, Andrew. I had 3 quick ones, but I'm happy for them to be answered outside the meeting if there's too many. Firstly, very good report, and thank you very much for that, and also very good presentations. Really appreciated them, and very impressive, all the work that is being done. I just had 3 quick questions. In the last meeting, we were told that the acute hospitals, Guy's and King's in particular, were being overloaded with mental health problems and having great difficulty in accommodating them. And I realise you haven't covered this in your presentation, but I just wondered whether or not we had been able to provide a bit more support to them. Second question was that in the paper that David produced to accompany the agenda as a supplementary paper, there was quite a lot about personality disorders. I don't think I saw in the brief presentation that we had today that was going to be incorporated in the Staying Well pilots. And I just wondered whether there was a reason for that, or whether it is in fact or not, because I think we have quite a high incidence of personality disorders in the community. And my third question was, clearly workforce and recruiting a workforce from a very much more diverse community is a big challenge. And I just wondered whether, with the focus on less clinical roles and a more broader spectrum of inputs, whether you had a work stream that was actually focusing on how to try and persuade people to join the workforce.
Thank you, Sue. And I see Neil's put his hand up as well. Was that a question, Neil, or was that did you want to make a comment? I suspect you know a little bit about this.
Yeah, so just to say I'm here to help colleagues if they want any questions answering. It was just notifying that I'm here.
Okay, thank you very much indeed. I had spotted you joining us. So Sabina, can I hand over to you and recognise you may not be able to answer all that in the meeting, and we can take some away. So yeah, go on Sabina.
I'll attempt to answer some, but we'll ask for colleagues' help that's on the call as well. So in terms of the disproportionality of Black and Asian colleagues in the mental health system, we do know that we still have work to do around that. So I don't have the figures here, Ed, but we do know that we've got work to do around that, hence some of the work we're doing with Black Tribe about having the culturally appropriate peer support. We are going to be reviewing the Mental Health Act white paper, which does talk about a lot about how we include the PCREF into work that we're doing, and we know SLAM is a pilot on that. Also in our business plan, we are thinking about how we look at access, experience and outcomes for our BME colleagues, and are doing work in parallel. So I don't know if other colleagues wanted to add to that, but that's some of the work in train that we do have. And 20 minutes is quite a short time to talk about everything that we are doing. In terms of the beds, and Neil might be able to help with this, I understand there has been a number of initiatives in terms of ensuring that we move our service users through A&E especially. So at the Maudsley, there was a new ward that was open to do exactly that. So patients that were waiting for admission could be transferred over and stay for 72 hours. In terms of daily basis, we have a bronze meeting where we're looking at who's waiting in A&E, not only for a bed, but for assessment and understanding what the staffing is. So there are things happening. We're also looking at some work with our winter pressures money in terms of how we support our class team to support further discharges. So there are things that we are doing. And my understanding is, and like I said, I look to Neil and Nozomi, that at the moment, I think Lambeth as a borough, we are holding using our beds as efficiently as possible, and in some cases supporting other colleagues as well. Going on to so for the personality disorder pathway, Sue, we are doing some work separately in terms of reviewing what our offer is, and because we're still reviewing it and putting that together, that's why we haven't included it in this presentation that we do, but there's some work happening outside that. And I don't know if other colleagues want to jump in, because I might have, and you asked about our workforce recruitment.
I can provide you, thanks Sue for the question around personality disorder. Yeah. I can provide you with a little bit of information of that, because I'm part of the group that's been developing that. What we're developing, and Nozomi's been working on this as well, is developing a stepped care model that basically starts with how can we support people early on in terms of resilience, self-guided care, moving through then to making sure that we work with partners, including primary care, to ensure that we have a kind of service that reaches into kind of partners in primary care, young people services, in sort of criminal justice, to work with those people who may not necessarily have a formal diagnosis of personality disorder, but you might have what you might call psychological and emotional adjustment issues that need some kind of support, and then to have kind of a tertiary model for those people who have got a very defined personality disorder, who need that kind of intensive kind of treatment, and we're being able to refashion and repurpose an existing funding from an existing service which is being decommissioned in the current delivery form to enable us to do that. So, and we can provide you with more details as and well where we've got the kind of offer more concretely set out.
And just the last slightly bit. Yeah, I can chip in a slightly bit more in terms of this proportionality. I was part of the review of the deep dive analysis of ethnicity as per different aspects of the care, especially acute admissions and detention and CTO. So yes, we are fully aware of a disproportionately high number of people under much more restricted care in the whole system of the BAME population. If you look, when we looked at more detail about what these BAME groups mean, that interestingly the highest number of people in all domains are categorized as Black other. So still I'm struggling to understand who this Black other group is. So I think it's much more than what we already know that we need to look into further. So, I can give you assurance that SLAM and Alliance altogether take the ethnicity and the disproportionality very, very seriously. So recently in SLAM, we have developed a proper dashboard for ethnicity for different aspects of care. And that's under regular scrutiny in all aspects, locally and trust-wide. So we are able to provide more data with much more detailed analysis in the coming month, I hope. And in terms of the bet, I'm so pleased to say that we are very, very efficient to maintain our capacity despite these difficult times. And in Lambeth Hospital, we are hosting only one ward across the whole trust to look after people who are tested positive. So, and despite that we've got this ward, the infection rate of the patients in hospital in Lambeth is less than other parts of the services. So I think this is a really good progress. And lastly, PD pathway, we have been in discussion if the name personality disorder pathway is the right one to reflect on what we are trying to do. What we are trying to do is to provide options and offers for people who need some support at a different stage of their journeys, if you like. So as David said, we will be able to provide, to present much more concrete plans and offers in the coming month.
Thank you all. I can see a number of hands have gone up. Are they for new points or are they to reinforce existing ones? So, was there something you, and Neil, was there something you wanted to add?
Yeah, so it was just in response to the GSTT and King's and supporting A&E demand. So as Sabrina pointed out earlier, we have actually stood up a 10-bedded unit, which is ring-fenced for A&E admissions across the 4 A&E departments that we serve. That opened up 2 weeks before Christmas. One of the positive things about that is also it's about us having just a little bit more time to work with people to see if we can actually step them down to intensive community care. The other thing that we're doing with GSTT is that we are currently in the process of establishing a clinical assessment unit within the A&E footprint at St Thomas's. That's going to be 6 bays. Which focus specifically on supporting people who are physically well enough to be cared for in that environment.
Thank you, Neil.
Care for them, yeah.
And Jenny?
I'll just say one sentence because I heard about personality disorders and staying well. Yes, we're discussing these kind of people a lot in our meetings, and it can be particularly helpful to I think for this group. So that is happening.
Thank you.
And
Sabrina, was there anything else? And then I think Penelope's got a hand up. Go on. Have to be quick because we're already nearly over time, and I've got one more item to cover.
Sue asked about workforce, and we are looking at developing a workforce strategy that would look exactly at how we get community people into our profession. So that's the last bit.
Okay, and we can perhaps give a fuller kind of response on that. Penelope, have you taken your hand down, Penelope?
Only an expectation that you would call me.
Okay.
I will be very brief.
Sorry.
I'll give a few sentences. So obviously as a GP, I will welcome anything which improves communication between us and the psychiatrists. Things always do go better when we manage to communicate. SLAM is a very big and monolithic, it appears monolithic from the outside, but internal communications can be hard. Some bits are harder to access than others. And I sometimes wonder how well and I appreciate you're not speaking for the whole of SLAM, how well they look after their staff. This morning I happened to be looking at statistics for the flu vaccination uptake across trusts across London. Oxley's Mental Health Trust has managed an 80% uptake of flu amongst their staff. SLAM did not even submit data. And I find that really sad. And I think that looking after your staff is really, really important, and happy staff make happy patients.
Thank you, Penelope. Neil, did you want to just respond on that? And I'm sure we can come back with a fuller response.
The submission of the data, clearly that's an error. We've achieved well over 70% of our staff have been vaccinated. And we've done that significantly faster than we did in previous years. So not only have we've gone beyond our last year's target, but we actually achieved that target 2 months earlier.
Okay, thank you, Neil. I'm going to move us on. Thank you to everybody who's contributed to that item and joined in today. I was going to name you all, but I don't think I've got time. I'm very apologies, and we've got people leaving, and I do want us to just take a few moments to do the last item. So thank you to all colleagues from Lambeth Living Well and everyone who's contributed. My sincere apologies, we are on time to finish. Can I just ask, is the board happy to stay on for another 10 minutes just to pick up the equalities item? Is that okay?
Yep.
Okay,
yes,
fantastic.
Very
My
important.
apologies. Okay, Di, I'm going to call on you, and we did this to you last time, I know. But could you shoehorn yourself a little bit into 10 minutes?
Sure. There were some slides. I don't know if Sam or Cheryl is on the slides. That'd be great. I always talk better with slides. I don't know why. But I was going to recap from our last meeting. You'll remember that we had a quiz, and I wanted to remind you all of the answers so that we make sure that we all, because we didn't get 100% for any of the answers. So where are my slides? Okay, let me share my own screen then, if that's not. Yeah, I don't have my slides readily available, so I was.
Cheryl, can we load
I've got a
them?
message saying they are coming.
Okay. It sometimes take a minute.
Yeah, it does.
Here we go. Can everyone see those?
Brilliant. Yes. So last time,
yes.
If we do the next one. So these are the questions again, so that you all get the right answer now. The under 75 mortality for all cardiovascular diseases is worsening at the moment in Lambeth. Next slide, please. Yeah, we didn't get that one right last time. When we looked at the Lambeth hypertension research that had been published internationally, we were looking at the strongest predictors of failure to control blood pressure. And we learned that actually it's men, and if you recall, it was men in their 40s and 50s whose blood pressure isn't well controlled. Next slide, please. Here are our thoughts. We thought that the ethnicity had the strongest prediction of failure to control blood pressure. We all had various ideas. The answer was Black ethnicity. Next slide. I think the last one was about the census from 10 years ago. Which country of birth has the largest migrant population to Lambeth? And you'll remember that the majority of us got the answer right. The answer is Jamaica, but coming up closely behind Portugal and Poland. And this year we will have a new census with new data to look at. And then there was one more question that we did that I'm going to remind you of, because we didn't all get the answer right for this one either. So it was all about maternal mortality, and there are some new documents just being published on maternal mortality, which shows that you're 5 times more likely to die during pregnancy or 6 weeks after if you're Black compared to being white. So last time we ran out of time, so I'm going to represent this. The next slide is a representative of the slide. So in smaller font, we said that we were going to do some reading. I hope that you've all had a chance to look at Michael Marmot's review, Build Back Fairer. There's an excellent executive summary. What we didn't get a chance to discuss really was organisational development. And we have had another Equalities Group meeting, and we've talked about it briefly, and we've had a very kind offer from Vimpy, one of our public health consultants, who's agreed to do a briefing for us as a board so that we all feel supported and meeting our duties. And the Equalities Group asked for a briefing on health equity and inequalities and the various languages that is used to make sure that we all get our definitions correct and use our language appropriately. The other organisation development that we're looking at, which I'd appreciate your feedback on, is some sort of board workshop that we can do in a seminar. We could do 1 hour every seminar, or we could do a whole seminar and give it over sort of 3 hours to some inclusion and diversity training. I've approached a company that has been doing the same work for the CCG, and they did it at an all-staff meeting, and they did it with the governing body. And their training is to look at key inclusion criteria, raise awareness of bias, specifically unpacking what does this phrase white privilege mean, what does this phrase about being an ally mean, and explaining how diversity, equality and inclusion affects patients and the outcomes of the work that we do. So it would be good to hear from board colleagues as to whether we could do this in one of our seminars and we could just schedule that in. In terms of the terms of reference, I did promise I was going to bring the terms of reference back to this meeting, but we've had a pandemic surge and we've also had some staff sickness. So at present, they're in draft format. Similarly, when we met last week, we've now got a draft work plan, which is around unpacking our data and then as you'll have heard just now, the Living Well Alliance have already got some excellent work ongoing looking at inequalities. The Neighbourhood and Wellbeing Delivery Alliance are starting to develop some metrics that we could look at. Clearly, our public health team are doing all the public COVID vaccinations. So I just need to work with the children and young people's and community safety team to see how we could incorporate some metrics from their alliance into the work plan for the equalities group. Right, I've seen some hands go up already. I'll leave it there for now. Yeah, the last point was about governance and how it all fits in, which we don't have to discuss today.
Okay, so there's a question in the chat, Di.
I can't see the chat right now.
From Sandra saying, "Who are you suggesting does this?" And I think she means the seminar and the training.
So it would be the Lambeth Together board members.
So this board, yeah.
Yeah.
And presumably we can invite others in from the
we can invite
delivery
people
alliances
from the
as well.
delivery alliances and the equalities group also. Yeah.
Okay.
No, I'm asked who is going to be delivering it.
Oh, sorry.
Oh, right. So the
There are
actual
some
name
really,
of the company.
really good people that do it, and it depends. To be honest, things like unconscious biases is kind of like gone out the window, and it's actually.
I didn't say unconscious. I said bias.
No, but even.
Yeah.
I'm just saying.
Yeah. So the name of the company are called Management Futures.
Okay.
And do you want the names of the? I mean, we haven't had the scoping meeting with them yet. It's booked for next week.
Okay. I suggest you bring back the spec and the scope, and we circulate that for review from people.
Yeah.
Once it's been to the equalities group. Okay. Neil,
Can we share that with the equalities team, please? The spec.
When we got it, yep.
I think Neil's got his hand up, or had his hand up. Or was he taking it? No, he's still got his hand up. Neil. You still there, Neil? You are on mute. Yeah. Neil, are you with us? No. Are there any other questions for Di? And then we'll come back to Neil in a minute. Neil's gone. Any other questions for Di? Penelope.
Yeah. Briefly, I attended recently, as in last week, some diversity training run by the BMA, which was a lot better than I had expected it to be, I confess. And this focused on how we behave in meetings and formal situations such as this, including online, which are really important and is one aspect of training. I think the sort of thing that Michael Marmot is writing about is more to do with policy. And these are equally important and one can feed into the other, but the training necessary for one is not the same as the training for the other. And I'm not quite sure what we're talking about here.
So
is that again about the scope of the training?
So it's the scope of the training. So they do a generic piece on inclusion, and so it can be inclusion amongst work colleagues, or it could be inclusion with respect to the provision or commissioning tasks that you do. So one of the events that I attended, it was more on workforce and how things happen around meetings, how things happen online, how people are excluded accidentally. But the other way you can do it is actually in terms of our Lambeth Together alliances and how we provide for our communities.
Okay.
So it's interesting just to hear people's comments because that helps me.
Okay, so
we'll leave it to the equalities group to get hold of the spec and to consider whether they think this is the right fit and make a recommendation back to the board. We don't have to wait for a board meeting to take a view on that. So if they can give us to the board members a recommendation, then we can deal with that virtually. And then if we have a package for a seminar session, we can obviously agree that outside of a board meeting. So I'm going to suggest rather than having the debate here outside of the equalities group, we ask them to come back to us with a further recommendation when you've got a kind of worked up options or a proposal. Does that make sense? Yep.
Okay. Was there anyone else had their hands up? No.
I did brief. I was just going to agree.
Sorry, Ed.
It's fine. I was just going to agree that, like Penelope says, there are two aspects, aren't there? The way we kind of behave with each other and understand white fragility and all of those kind of concepts, which are really important, and then it intersects with the way that we commission and provide services that are appropriate for our population, a bit like the mental health conversation we just had, and they are connected, but it's right to kind of interrogate who is providing them, because like Sandra says, you know, some companies have better reputations than others, and some approaches do. So I mean, I'm perfectly happy with the approach you've set out, Andrew, which is for the equalities group to go away and look at that, and I think it's really important that we do, given the kind of disproportionality that we all know about. So, and I think those two approaches work well together. It's just managing how they interact, if you see what I mean. The way we understand our own potential biases and the way that manifests itself in our behaviour towards each other and others, and then the way that we commission and provide appropriate services for our diverse community.
Okay, thank you, Ed. So obviously people can get in touch with Di if they want to contribute to that, and then as it travels through the equalities group, and then we'll come back at a point with either some options or a recommendation for this board to consider, probably over email, I think, rather than waiting for a meeting itself. Is that okay with people?
Yep, appreciate that.
Yep.
Okay, thank you all very much. And thank you, Di, for picking up and leading on this work along with the rest of the equalities group. It's the one bit we didn't want to lose out of this agenda today, because it's important. We started off last time and we wanted to keep the momentum, even if we've curtailed the kind of length of the meeting and so on. So thank you very much. My apologies again to everybody for running over time, and thank you for offering up an extra 10 minutes or so. Unless anyone's got any other questions or any other business, I'm going to suggest we stop there and play the Mosaic video. But is anyone, just before we do that, is anybody wanted to raise before we closed? I can't see any hands, so I think that's about it. So thank you all very much. And Sandra, say goodbye to your cat for us in your background. So if we could all say goodbye, and then we can probably run the video for anyone who could stay on for another 6 minutes. So I'm going to hope the video can play. We have had problems with videos in the past, but let's see how we get on. So thank you all very much. Thanks to all our contributors. And speak to you all again very soon. Thank you very much.
Thank you.
Bye.
Our motto was our building was closed, but our community remained open.
Here at Mosaic, we found the pandemic very tough. For the first time in our 25-year history, we found a way of working with everybody virtually. It was very vital for everybody to stay connected with everybody.
My key worker name is Dear Almas. During the lockdown, she sent me cards and she phoned me to see if I was well.
We held our unit meetings on Zoom, and our newsletter In the Mo started to come out weekly, filled with so much great member content.
Members created new ways to keep in touch, running a film club via Zoom, an art and writing group via email, even a radio station where you could request songs.
While our building was closed, our cafe was being used by Street Kitchen to provide hot meal for the homeless people, which was organized by Lambeth Council.
Unit meetings by Zoom were a lifeline. I'm just so grateful that Mosaic remained active during the lockdown and found different ways to reach out and engage its members. Without Mosaic, I dread to think what would have happened to my mental health.
I was so pleased to have staff checking on me during lockdown. I haven't got a smartphone or a laptop, So it was great having staff ringing me every day to check in to see that I was okay.
Lockdown was quite challenging for me. I found the lack of structure really hard. I missed social interactions and services. I felt isolated and alone. I ended up having a mental health crisis, and I got support by phone from the evening sanctuary. I found these calls really helpful. They listened and understood me. They were really compassionate. They gave me time. It made me feel like somebody cared.
We reopened the building in July, first with the evening sanctuary and then the day service. We introduced new ways of working in order to keep everyone safe, including social distancing, limiting the number of people in the building at any one time, as well as having time slots for members. In September, we also introduced masks, so every staff and member needs to wear a mask when in the building.
We have brought back yoga and Keep Fit. I've been going to Keep Fit. I'm enjoying it.
Just this week on the news, a reporter was talking to a pensioner in the US, largely about their election vote. But at the end, the man finished off by saying something that I think really sums up the past year. Yeah. I've lived through the civil rights movement of the 60s, Vietnam in the 70s, the Cold War, 9/11, and a whole lot more besides. And I can now say I lived through 2020. We have had it all and are still living through a pandemic, economic uncertainty affecting employment, a generational social movement, and all the while, the most helpful thing to do has been often to do nothing. Which to me seems to have given the population in a microcosm a very similar experience to the one most people encounter when they suffer with their mental health. A pervading anxiety, which is only fed in an isolation that feels helpless. At these moments is where you often just need someone either to talk with about whatever, or maybe even just their presence. This has meant those you live with, or on the occasions when you've been able to get to Mosaic. Or, as has mostly been the case for me, when Mosaic actually reach out to you just for a chat to see how you're doing and that everything's okay. I feel I've personally struggled less than others during this pandemic, but it has been a real support to talk to someone outside my house every week and to just have that sense that things are going on beyond my windows. Possibly a reason I haven't struggled as much as others is because for a lot of the year I had a very definite goal in the London Marathon, and that's something I would definitely recommend to anyone struggling with their mental health. Having a goal. Doesn't even have to be a goal as such, but just a set date or a set event to give you a bit of a direction or purpose to your everyday. However, what has actually been most striking to me in the process of preparing for the marathon and raising awareness for it is how mental health is an issue for everyone. After I said a little about myself and Mosaic, people started talking to me about their own struggles with mental health, people from all walks of life and all in different situations. And these were people who were either family members to people I barely even knew. So what I take away from it all is to be less afraid of being honest and frank with your mental health, because in all likelihood that person will be struggling as well.
Really good video.
Very good.
Yeah. Excellent.
Fantastic.
Great work they're doing.
Yeah, it's really good. I don't know if anyone's left from Lambeth Living Well who can pass on.
Will do.
We will do.
Congratulations on that. It's really good. Okay.
Yeah, great stuff.
All right, and thank you, Cheryl and Sam in the background, for sorting out the all the slides today and everything. So thank you all very much, everybody. Sabrina, thanks for taking us through the mental health stuff. So I couldn't quite see who was still left on camera. So. Thanks, everyone. And,
bye, everyone.
Good sharing, Andrew. Well done. Thanks, Sabrina.
Not that
Great
good.
work.
Finished half an hour.